Hi there, I'm Jamie Taylor. Welcome to Your Health Matters, brought to you by Kingman Regional Medical Center, your community-owned hospital. Every week on this program, I have a different healthcare professional that we talk to who has information for you and your family about programs, services, or healthcare issues that I think will be relevant to you and your family. I've got an exciting guest on the program today, so stay tuned. We'll be back right after these messages. Welcome back to Your Health Matters. My guest today is Dr. Stephen Whipp, who's one of the newest Kingman OBGYN associates. Thanks for being here today.
You're very welcome. Thank you for having me.
And I say new, but as we were talking before the show, you've actually been here for 8 months? No, longer than that.
Yeah, since July 1st.
Almost a year.
Yeah.
Good grief, time flies when you're having fun. So, from what I understand, you kind of hit the ground running. You've been delivering babies like crazy.
It's been busy. We're a very busy practice. We're the only practitioners left here in town, and it's been pretty darn busy.
So pretty much every baby comes through your guys' hands.
They do. That they do.
That's one way of putting it anyway. So how did you end up becoming a baby doctor? You might mind asking.
You know, I went to medical school in Houston, Texas, and I always thought, I was in the Army for 9 years prior to that, and I always thought that I was going to go into psychiatry. Child psychiatry always kind of really appealed to me. I did my rotation of obstetrics late in the year, and you know, after doing it, I just fell in love with it. You know, as I look at different doctors, you know, and speaking to my family, nobody ever forgets who delivered the baby.
That's true.
You might forget who gives you your high blood pressure medication. You might forget your diabetic medication, but you never forget who delivered you.
That's true.
And to me, that really, really appealed to me. And plus, it's rare in medicine nowadays, unfortunately, that you see people happy when they come through the hospital.
That's true too.
And our patients, for the most part, are very, very happy. And so it really appealed to me.
It's true. You are one of the positive parts of healthcare.
Yes.
Having a baby is,
Yes.
is a wonderful, life-changing event.
It is. And it's a very special feeling to be actually allowed to share that moment, you know, with our patients. So
That's awesome. And is it 4 or 5 of you now? There's 5, right?
I'm the 5th one.
Fifth
yes.
one, because we have Dr. Tedesco, Dr. Taylor, Dr. Lemansky, Dr. Jackson.
And myself.
And yourself. So that's awesome. We have a team of 5, and which is a good thing, because babies have a tendency, of course, to come odd times.
They come at really good times, between 11 p.m. and 7 a.m. in the middle of the night.
Almost, right?
Well, and it's good, because I'd been a solo practitioner previously.
Oh.
And you know, I have 4 children of my own, and it's very difficult. You know, it's very difficult to plan to do anything in your own private life. And it's been great. You know, having people like Dr. Tedesco and Lemansky, who've been doing this for a long time.
Right.
You know, to really kind of show you the ropes, and it's been a wonderful experience.
And you have people to share the joy with.
We do. My wife. I think my wife's the happiest about this.
She is.
Definitely.
Very good. So before I forget, then we'll talk about family for a minute. So where were you before Kingman?
Well, we've been a couple places. I had actually practiced at Western Arizona Regional down in Bullhead.
Oh, okay.
Didn't really care for the being on call by myself. Thought that I was a big city boy.
Yeah.
An opportunity presented itself down in Phoenix, and I ran for the hills, thinking that it'd be great to operate, work in the city. When I was down in Phoenix, you know, the opportunity that was presented to me really wasn't the opportunity that was there. And so after being there for a year, you know, speaking with my wife, we just decided, you know, let's go back here. My wife happens to be from Bullhead City.
Oh, okay.
I had known Dr. Tedesco and Dr. Taylor prior to leaving, and I knew the good standard of care that they were delivering up here. Plus, it was nice to work with 4 other people. And so my wife and I decided to come back up here to be close to our family, but not too close. And we were lucky that there was an opportunity here for us.
That's awesome. That worked really well.
It has.
Very good. And so you have 4 children, and how old are they?
16. We have a son who's 16, a daughter who's 6, another daughter who's 3, and a baby who's it'll be a year and 13 days.
Wow, that's a big stretch.
Yes, maybe one more.
Oh, well,
that's on film.
Does she know yet?
She does.
Oh, okay.
Well, we're not there yet, but we've had the conversation.
Okay, very good. That's too funny. So do you primarily, are you obstetrics, or do you do gynecology as well?
Well, you know, the thing is, generally when you come to a new practice, you usually focus more on the obstetrics as far as getting to know the patients, and then after a while, it's after earning that trust and getting your name out in the community that you start segueing more to the gynecology.
Okay.
Our practice happens to be so darn busy that we do a lot of both. If I had to put a percentage on it, I would say I probably do more around 70-30 as far as obstetrics versus gynecology, where the other partners in the practice are more 50-50.
Okay.
But it just takes time.
Sure, building that, like I said, the client base up too. So obviously you see a lot of babies, and I'm not sure about the current year. I know my experience in my 10 years here at KMC has been we've averaged around 650 babies a year. So are we kind of staying on track for that?
Yeah, we're kind of staying on track. You know, despite fluctuations, or fluctuations, in the economy, a recession versus non-recession, Obamacare versus non-Obamacare, people still have babies.
Yeah, that's true.
And it's kind of an independent factor as far as that's concerned. And we've been pretty average across the board as far as our numbers.
Yeah, they've been kind of staying pretty.
Yeah, and for some reason it seems like people have more babies during the summertime. I guess it's more of a reason to cozy up during the wintertime.
I was just going to say, is that cuddling in the winter to stay warm?
And the result is summertime babies. And so we're starting to get into more of a busier season.
Okay,
yeah.
That's funny. I hadn't thought of it that way, but it makes sense too.
Definitely.
So the kind of, I mean, you're delivering babies, but hopefully you see the mother through the whole pregnancy. I know that is sometimes a challenge for us here in Kingman, is getting the moms in for their early prenatal care, right?
Right, and that's one of the benefits, I think, of our practice here. As I said, I've been other places, and generally our payer mix is mostly the state Medicaid or access insurance, and sometimes it can be difficult for the patients to, once they find out they're pregnant, to actually step through the hoops to get the insurance going. But we really recommend having them get the insurance as quick as possible, because what we offer what's called OB orientation, and what they'll do is we offer 2 to 3 times a week. They'll come in there, they'll get prescriptions for prenatal vitamins. We do a rudimentary ultrasound so we can determine their due dates, so we can actually determine that they are pregnant, and we can get them started on a good prenatal care path.
And that makes a big difference for a healthy baby.
Well, it does. And other places I've been, some of these women, they weren't finding out till 18, 20 weeks along. And when you're 18 or 20 weeks along, or when you're in the second trimester and you have an ultrasound, that ultrasound can be off by either 2 weeks in front or 2 weeks behind. And some people might say, well, what's the big deal with that? But the big deal as far as an obstetrician is concerned is that every decision we make throughout the prenatal course, it's all dictated on where that patient is in the pregnancy line.
Okay.
The first thing we always ask is how far along she is, because our decisions change throughout the course of the pregnancy.
As you're watching and kind of.
So it's incredibly important to get an accurate due date as early on as possible, and as early on, the earlier you establish a due date, the more accurate it is.
Okay, that makes sense. And what are the kind of things that you think maybe a lot of our moms aren't aware of that they need to do better about taking care of themselves and their babies?
Well, I think one of the main things, we don't have as much of a problem here in Kingman, but obesity. I mean, I think as far as pre-pregnancy weight, taking care of themselves pre-pregnancy, as I made light of earlier, my wife and I are thinking about having a child, and if you think you're going to think about having a child the next couple of months, it's really important to start prenatal vitamins prior to that.
Oh, you're going to start even before you get pregnant?
You can. We recommend usually 3 to 6 months prior to that. Because what ends up happening, one of the main components of prenatal vitamins are folic acid. Folic acid helps helps the developing neural tube. The developing neural tube is closed in a appropriate sized or in a normal pregnancy, approximately day 27. Day 27, day 28. A lot of patients don't realize they're pregnant until 4 to 6 weeks after the missed period, and so it's too late by that time. So it's really important to try to get the prenatal vitamins and the folic acid on board prior to that.
Okay.
And also, if you're a little bit overweight, and if your periods are kind of irregular, by getting yourself into shape, having different strategies, it'll help for a better outcome, and the better outcome being a vaginal delivery.
Right. Yes. Because I've heard that too. That. Nowadays, and not that it's necessarily a bad thing, but we do a lot more C-sections.
We do.
And
we do.
Is that kind of a trend you've seen through your career, or?
I think, honestly, I think it depends on where you're at. I think here, and I'm not just saying this because I work here, I think here we have a pretty low C-section rate.
Oh.
We have a lot more experienced practitioners. I mean, prior to me, I've been out of residency for 5 years now, and I'm the youngest.
Mm-hmm.
Dr. Taylor, I believe, has been out 12 years, and then you have Dr. Tedesco and Lemansky. They've been out for a while, and Dr. Jackson as well.
Mm-hmm.
With age comes experience,
right?
And it's with that experience, with the different fetal monitoring, to kind of allow for more of a vaginal delivery. What I've noticed when I was in the big city is that the C-section rate is very much increased. What ends up happening is you get a lot of 9 to 5 doctors.
Oh, they just want that baby.
They want the baby out so they can go home and eat dinner. I'm not saying that's I know that's a generalization, but it's what I've seen.
Yeah. And that's too bad.
Well, and the problem is once you've had one C-section, the current recommendation is every successive pregnancy should be a repeat C-section. And so you're going to increase the numbers no matter what.
Now, that's an interesting point with that, having successive C-sections. Is it because once you've had it that you've had that weakness of?
Well, what ends up happening is, when we perform a cesarean delivery, we make an incision on the uterine muscle. The uterine muscle is no matter how well you stitch it up or you suture it back up, it's not going to be nearly as strong as it was pre-cut. And so you can have up to a 10% risk of that incision opening. And the American College of Obstetricians and Gynecologists don't recommend a vaginal delivery, or what's commonly known as a VBAC, or vaginal birth after cesarean, to occur. Back in the 90s, they would try it a lot more, but what ended up happening is you'd get a uterine rupture where that suture line would open up and babies would unfortunately expire. And so now the recommendation is once a C-section, pretty much always a cesarean delivery. And actually our hospital policy is to not allow for a vaginal birth after cesarean if possible.
Yeah, well that makes sense because it's all
dangerous.
about what's best for the mom and the baby.
Right, and and as I tell a lot of our patients, when you're at that child's high school high school graduation 18 years from now, you're not going to care how that baby came out.
Yeah.
All you're going to care about is that baby came out healthy.
That's a good point. That's really well said.
Oh, thanks.
And it is the most important thing. So, and of course, having that baby and like fetal monitoring, and I think we should talk a little bit about that, because that's one of your tools, right, that you use to make sure the baby's not in distress.
Right. Well, it's funny. It's a little known fact, but it's kind of a funny fact. The only thing that fetal monitoring, because fetal monitoring is the standard of care now. When you come to the hospital, you get the monitors on you. You get the contraction monitor, and you get the fetal heart tracing monitor. Back in the old days, they would just come by with a fetoscope or listen by a stethoscope to hear the baby's heart rate every 15 to 30 minutes if they're in labor or not. Since the advent of fetal heart tracing, the only thing that's improved or increased is the cesarean rate. Because now you have a monitor, now you have a descriptor. If something comes out of the ordinary, you're kind of forced to act on it.
Right.
But it is, as of right now, it is our best test as far as determining fetal stability and fetal outcomes.
Making sure they're moving along the way they're supposed to.
But we all, and I know across the board as far as our practice, we all want every lady to deliver vaginally if possible. However, you can't always control that. Sure. Unfortunately.
But it is the best option, obviously. Get back on your feet faster and.
Well, get back on your feet faster. It's healthier for the mom. It's better. It promotes better. It's a lot quicker to bond with a baby. And a lot of our women have other babies at home or other children at home. And it's tough after a C-section. I know you see these women in Hollywood having cesarean deliveries and they're back to work 6 weeks later.
Yeah.
They also don't show the nanny that they have with them.
They got a nanny and a cook and a housekeeper.
Exactly. And cesarean delivery, despite even though it's become very popular and very
easier than it used to be.
It's still a major surgery. We're opening up the skin and we're going into the abdominal cavity. And unfortunately things can happen sometimes. And it's still a major surgery, and so we don't take it lightly. It's not something we try to pursue, but when you're worried about a baby, you have to do what needs to be done.
Yeah, right, absolutely. So you mentioned earlier about diabetes and obesity. So what are the kind of things? I mean, obviously, watching her weight is one of the best things we can do, but if a woman's in her pregnancy and ends up getting, is it called gestational diabetes? Then what do you do, and how do you handle that?
Generally, as far as gestational diabetes is handled, if this is a person's first pregnancy or they've had previous pregnancies not affected by gestational diabetes, the standard of care is to perform a 50-gram sugar load, or what we call the diabetic screen, between 24 and 28 weeks. If that can come, it's a screening test. If it's below 140, it's absolutely normal. If it's above 200, it's automatically a failed test. You're automatically labeled gestational diabetic. There's a gray area between 140 and 200. If it comes back in that gray area, we're forced to do what's called the confirmatory test, and that's the 3-hour sugar test.
Okay.
Not a very fun test. It's a 100-gram load, and we draw the blood level at 4 different times.
Oh, wow. Okay.
And so if that comes back positive, what we end up doing is we send them over to the nutritionist, and we try to control with diet.
Okay.
And so we send them to the nutritionist. They start checking their blood sugars 5 times a day. And if that doesn't work, we kind of monitor their sugars over the next week or so. If that doesn't work, in the old days, we'd give insulin. Now we have a medication called glyburide that we can give by mouth that's a little better tolerated, and we notice with our patients that they'll actually take the medication.
Great. We'll continue talking about that. We're going to take a quick break.
Sounds great.
So stay tuned. We'll be back and learn more. We hear all the time through the rumors, oh, Kingman has such a high teenage pregnancy rate. Do you think it's higher than other places you've been? Welcome back to Your Health Matters. My guest today is Dr. Stephen Whipp. Thanks again for being on the program.
You're very welcome.
So before the break, we were talking about gestational diabetes, and you were sharing that there's a kind of a process you go through. When they get through that whole thing and it's definitely they have the gestational diabetes, then what's the next step? What do you do?
So like I said, as we talked about prior to the break, we try to control with diet at first. If they can't, if they're still kind of the sugars are a little bit out of control with that, we then switch into pharmacological means. In the old days, I meant insulin. We found that a lot of young ladies don't want to. It's bad enough they have to check their sugars 5 times a day.
Right.
But if they're having to inject insulin as well, not as good of a compliance rate.
No.
So luckily they developed a medication called glyburide, which is a peripheral. It helps in the periphery as far as uptaking the sugars and sensitizing the receptors in the body. We start patients on that.
Okay.
Some might ask, well, what's the big deal about gestational diabetes? You worry about macrosomia, or the baby being too large, and actually having birth trauma as it comes through, and it also increases the cesarean rate.
Okay.
A lot of these babies, they'll have the fat distribution is a little different. It's more located in the shoulders, and so thus much
Makes
more
it harder
difficult.
to get through. Yeah.
Right. And the big thing you worry about as far as at the time of delivery is something called what's called an obstetrical emergency, or shoulder dystocia, where the shoulders can't deliver through the vaginal opening.
Right.
And so if
So they
that's the
literally
case,
get stuck?
they literally get stuck, and unfortunately it becomes an emergency, because if you can't deliver from below, you got to deliver from above.
Right.
And
they're already in the birth canal.
They're already in the birth canal, and if it's 3 o'clock in the morning, it's somewhat difficult to get back to the operating room quick enough.
Yeah. Wow.
So it can go south very, very quickly.
Okay. So that's all the more important reason why that
It really is.
prenatal care and
Well, that and gestational diabetes, women who are diagnosed with gestational diabetes, they've said in 15 years after pregnancy, you have up to a 30% chance of acquiring type 2 diabetes. So it's really, really important as far as the long run of a patient's or of a woman's morbidity and her long-term health.
Okay. So this is probably a touchy subject, and I'll apologize ahead of time, but teenage pregnancy rate is something that we hear all the time through the rumors, oh, Kingman has such a high teenage pregnancy rate. Do you think it's higher than other places you've been?
I think it is. I think it's a little higher, but I don't know, I'm not sure if it's just a spike right now, or if it's just, because it seems like throughout time you always have ebbs and flows, peaks and valleys. We do seem to have a higher pregnancy rate, as far as our younger ladies. But, we're not really sure the exact reason of that. I mean, could it be there's not as many programs for the women? Is there a higher dropout rate from high school? We're not really sure.
Lack of education, and
conversely, do the women who graduate high school and they go off to college, those women move away?
Oh, and true. So we don't know.
That can also skew the rate as well.
Right.
So it's really kind of hard to tell.
That's interesting. Well, one of the things I have to say that I think, in talking with friends, it's been a long time since I had my babies. I've got grandbabies that are grown up now. I can look forward to great-grandchildren soon. But having a team like you do, those 5 doctors, and like you talked about, it's having the backup, and so you're not on call 24/7. But I think what I've heard that women really appreciate is that as they're going through their prenatal care through the office, that they have an opportunity to meet each of you. Usually you stagger their appointments, so they're going to meet all of you at least one time during their pregnancy. And let's talk about that. What's the benefit of that?
Well, the benefit, I think it really helps decrease anxiety. You know, unfortunately, gone are the old days where, you know, if you had one doctor, that was your doctor. You know, I think that's one of the reasons that appealed to me in obstetrics, because it's nice to be labeled as so and so's doctor.
Right.
Oh, that's my patient.
Right.
You know, it's a great feeling, and it makes you feel good. But you know, we have, you know, with the 5 different doctors, the reason we kind of do that is, you know, we are 5 people, and, you know, we all have our families. As I stated previously, you know, we have 4 children. And of course, you know, you want to be true to your patients, but you also have to be true to your family as well.
Need to have a little bit of a life.
Yes, definitely. And so, you know, with the 5 different doctors, you know, our thing is we don't want the woman, we can't always guarantee who's going to be there at delivery. And so throughout the pregnancy, we have all the patients meet every doctor. So when it's time for delivery, and, you know, you might have the best laid plan. Oh my gosh, I want Dr. Taylor to deliver me. Or, you know, Dr. Tedesco said he would come in to deliver me. Well, maybe the lady, her bag of water broke a week early, you know, versus your best plan, and Dr. Tedesco or Dr. Taylor's not in town.
Right.
As long as you either met Dr. Whipp, Dr. Jackson, Dr. Lemansky, at least you can say, oh my gosh, who the heck are you at the time of delivery?
Not a complete stranger.
Or they can send you through the roof. I mean, it's you know, if it's a first-time mom, it's scary.
Yeah.
And I think what ends up happening throughout the course of pregnancy, I wouldn't say patients get dependent, but, you know, you form a relationship.
You do.
And you form a bond, and, you know, you kind of want, you know, you become interested in that person as far as you want the best for them.
Yeah.
And, you know,
well, you're seeing them for 9 months, so for a good stretch of that.
Hopefully 9 months.
Yeah. And so you are going to build a relationship with them during that time and get to know them a little bit more on a personal level, probably even than you do a primary care who sees their patient once a year for their well woman check or something like that. You see them more. Yeah,
and for us, the way we kind of look at things from the clinic perspective, is we tell all of our patients this at the beginning. I know prior to coming to this, right here, I just had 2 new patients, and I was explaining this to them. From what I've noticed that happens is that all the patients see all the doctors, and towards the end of pregnancy, they kind of gravitate towards one doctor or the other. There are certain people who love there's a lot of people who love Dr. Taylor, Dr. Tedesco, Dr. Lemansky, you know, Dr. Jackson. And what ends up happening is you fill out who you fit with a little more, and towards the end you start seeing that person more. We can't always guarantee we're going to be there at delivery, but, you know, for the most part we try to be.
Very good. And what are the kind of things now? I know you do like a baby shower, I think it is.
We do.
Once a month, is it? Or?
Yeah, once a month on Wednesday afternoons. We bring the ladies who are in the 3rd trimester. We have what's called a baby shower. So we go to one of the conference rooms in the hospital. We bring somebody out from labor and delivery, and we kind of just have it's a question and answer session where we talk about the perils and pitfalls and the expected labor course when they're admitted to the hospital. 1, from the doctor's perspective. 2, from the nursing perspective, as far as what they're going to expect to happen. We also have a little raffle, and they usually raffle off a car seat.
Oh, very good.
Yeah, and so from the feedback that I've received from it, it seems like our patients really like it, and I think it's really more beneficial for the first-time moms,
especially,
or the ladies who moved here from out of state, or the ladies who might have been delivered by another practice prior to this, and, you know, it's good. It's kind of more of to quell the anxiety as well.
Sure, and knowing kind of what's coming down the pike and who you're going to be talking to, or
right, because they'll ask questions about, you know, what happens. Am I going to get an IV? What about pain management, epidural versus IV pain medication? Is the doctor going to be there? How are they going to give me contraction medication? All these questions that mostly are answered in the routine OB visits. You know, if they're not answered at that time, we can answer them at that time.
Well, and don't you encourage the dads to participate?
We do.
In that too.
We do, and unfortunately, that's something that I see more as time has gone on. We don't see as many dads as involved. It kind of saddens me.
Yeah.
You know, because baby needs both parents.
Yeah, absolutely.
It really does.
Well, and I think, you know, again, we've talked about there can be many things that impact that. Nowadays, with our economy, what it is, of course, a lot of those dads are having to work 2 and 3 jobs.
You have to do what you have to do.
Yeah, just keep food on the table. But at the same time, the more involved they are, obviously through the pregnancy. I mean, I've been very blessed watching my son-in-laws and their involvement too with our newest grandchildren, and they're very involved in that whole process. And it's a team, the 2 of them.
Well, I think it's better for the woman. I think you know it's. Unfortunately, I see a lot of, especially our younger ladies, come in there, you know, without a significant other, and it's stressful. You know, the mom can only help so much.
Yeah.
You know, and it's scary. You know, they've never been through this before, and it's, you know, it's a life-changing event.
Yeah, it really is. Yeah. Other options or health issues that you're aware of that you think our audience should be?
You know, the only thing that I've noticed, and I think it's a common question out here, especially in the Mojave Valley, is the increased methamphetamine usage. You know, unfortunately, we do have a lot of patients, you know,
who they're coming through pregnant and
they're either positive for that, and what a lot of patients don't realize also is positive for cannabis or marijuana. You know, the standard protocol is if you're positive for marijuana or have a urine drug screen that's positive, Child Protective Services has to be involved.
Oh.
And I think sometimes the patients feel like we're trying to get them in trouble, but we're not. But we want the same thing that they want, which is a healthy environment for the baby.
Yeah.
And so if people are, you know, doing that kind of recreational activity, you know, if they're hoping to become pregnant, they kind of want to stop.
Right. Absolutely. Best for the baby too.
Definitely.
Thank you so much for being on the
Thanks
program. It's nice to finally get to meet you in person. Thank you, Dr. Whipp. I hope you learned something new today. I know I did. Join us again next week, and I'll have another exciting guest in the program.